of dear Pujari. I have live streamed, started the live stream and everything is all set up both in
Right.
on YouTube and both on Facebook and LinkedIn. They are all announced, so it's um, all done. Sometimes uh, it's better to do it before everything starts. So I'll just
Absolutely.
uh, and sometimes if I start in the middle, it starts this echo. So it's figured out. And when the echo comes inside your computer, you don't realize it because it's behind your screen, and it's like searching for whether it's in your head or is it on the computer. Let me see whether speakers are here. Hello, no, hello, Professor Moroto. Professor Moroto.
I was actually looking for share, side view, side to side kind of view,
Oh,
but
yeah.
I am not able to get that. That option does not exist here.
Mm, I have to check that. I only figured out, I only saw this side to side some today when I was going through some control. What's a
Uh-huh.
side to side? I have not come across that. What is a side to side view?
Uh, because what is happening is that the screen where you and me and our chairperson is seen,
Yeah.
that actually compromises some space of the slideshow.
Oh, okay, okay.
So you can actually separate them if you opt for a side-to-side
Oh,
show.
oh, really? Okay. I'll have a look into it. I saw it somewhere only today. I said, what's this
It's
side to
there
side?
in Zoom. I don't know some.
I think I might have to, uh, on the settings, I might have to just change the settings some.
I actually Ulrich's talk. I saw it that way, but to
Oh,
when
just,
I started sharing the screen, that option seems to have gone from my screen.
oh, yours has gone. Let me just see. No, you are already on the sharing the screen.
Yes,
Or on your sharing the screen.
that's right. So
So at the moment you are sharing the screen,
yeah,
and maybe
optimize
yeah,
share.
I see it now here. So how what you do is that if you take your cursor to the top of the screen,
Yes.
you will see that there will be a green bar which says you are sharing the screen, and next to it it will say view options.
So that view options has gone from my
No, you have to move your
screen
cursor to the top of the screen, then it will appear again.
using enhanced.
If you move the cursor to the top of the screen, then it should appear.
No, it has been there all the time, but it has just gone. I
No.
don't know where it has gone. It's showing me. It's okay. I think I should be able to manage.
Okay, okay. Certainly, at the moment, without realizing, mine is side by side mode. Uh, I see what you mean. So when I take the side by side mode off, then the whole screen becomes, you can see the whole screen is better, isn't
Correct. Correct. You can see your own slideshow fully.
it? Okay. Thanks. Thank you for that. It makes a big difference. Uh,
Yeah, you otherwise you lose part of your screen. So
screen. When when you move your finger, move your mouse, nothing is coming up. No, when you take it to the top. No.
it's not coming up now. It
Mm.
it
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 was
was
there.
there half an hour ago during the last talk, and it's just not there.
Or
Uh,
these techno, I never play a computer game. I'm happy to lose to a
yeah.
human. I'm happy to lose to a human than a computer. Same goes with this. As much as I might be computer, but I'd rather have a.
Well, if you are saying that, then I think ordinary mortals we won't be able to.
I do so sincerely. I'll get uh, so. Professor Moroto, are you there? He must be.
I saw him yesterday. I haven't seen him today yet.
Great, thanks. We are just 1 minute away, so I'll just get Marek. Hello, Marek.
Yeah, I'm here.
Great.
Okay.
Thank you.
I'm just turning on.
Excellent.
Can you hear me? Yeah?
Yeah.
It's okay?
Yes, we can hear.
Fine. Okay.
Great. Good morning again from the UK, and good afternoon and good evening to those from further east. So welcome back to this late morning session. We have another fantastic program with eminent speakers. It gives me great pleasure in introducing the chairs for this session. Is Professor Marek Mandera. He's from Professor of Neurosurgery at Silesia in Katowice, Poland. I have known him for the last 3 or 4 years, and he has been a great supporter of ListServ, and it's a real honor and pleasure to have him here. And his particular interest is craniopharyngioma, so he can bring some insights when questioning comes. And we also have Mr. Pasquale Gallo. He's a consultant pediatric and adult neurosurgeon at Western General Hospital in Edinburgh. It's great to have Pasquale. We have certainly my seniors are very proud that he had come through the Birmingham training, the fellowship. So without further ado, I hand over to Professor Mandera.
So Naren, can we start? Yeah?
Yes, please. Yeah.
Okay. So first, I'd like to congratulate Naren for organizing such an excellent online conference. I am impressed by your outstanding activity for Neurosurgical Society, so I am really happy to be part of this event. And let's go to the first lecture. I think Professor Del Pujari is very well known to most of participants, if not all, as he is an expert neurosurgeon with a high number of significant publications. He presently serves as professor and head of neurosurgery at Bombay Hospital Institute of Medical Sciences, and he was also invited to be on editorial board of several prestigious journals and holds significant posts in Indian and international societies. So I am sure we have an opportunity to listen to a really expert lecture on craniopharyngioma. And Professor, please start with your presentation.
Thanks, Mark, and thanks, Naren, for this opportunity. I really congratulate you for this wonderful organization, and I'm really feeling sorry not to be meeting in Mysore. Bombay is particularly very badly affected, as most of you know, and we are in a real bad state in terms of increasing number of cases and a lockdown, which has really brought our regular work to standstill. And it's a struggle to get to the hospital, and it's a nice break to have meet a lot of old friends, though virtually, and share some thoughts with you. So I have this series where more than almost 60%, 65% patients are children, and about 30% patients are adults, and a few patients between 18 to 20 years. And I thought I would share my current thoughts on how we treat them and what seems to be the future. So basically, craniopharyngiomas, according to WHO classification, are WHO grade 1 tumors. They are benign, partly cystic epithelial tumors of the sellar region, presumably derived from Rathke's pouch. And if you find that the frequency where epidemiological studies are well maintained in US, almost 1 to 3% of all brain tumors. And if you look at children, it's about 5 to 10% of brain tumors in children, especially in Japan, Africa, in South Asia, and even in India. I think in major centers, we see quite a lot, though we do not have a definite epidemiological study. The study done on brain tumors in children in India below the age of 16 years had shown that this was number 4 tumor in the practice of the major centers. A recent article in the Nature's Review has actually put it very nicely, Dr. Muller's group, that these are the malformation tumors of low histological malignancy. And now we know that there are definitely two types, the adamantinomatous and the papillary craniophryngiomas, which have different characteristics. And treatment comprises, of course, surgery, radiotherapy, and intracystic chemotherapy. And given the rarity of these tumors, we still do not know what is the ideal combination, and international collaboration should be there. For quite a long time, we have known that there are two varieties, adamantinomatous and papillary. The recent knowledge that there is a in molecular biology, that there is a CTNNB1 mutation in the adamantinomatous type, and a BRAF mutation is seen in papillary craniopharyngiomas, are probably important in future directions for treatment. Morphologically, basically, we see sometimes only a monocystic craniopharyngioma, not very common, but relatively common in children. Then we see tumors which are densely calcified, and then more commonly we see what are the mixed tumors. We are discussing today craniopharyngioma children, and as you know, there are certain differences between the two, and therefore we are restricting today's discussion mainly to children. In children, the signs and symptoms are usually associated with raised intracranial pressure, while in adults, they are usually the visual field defects. While hydrocephalus is present in more than 40% of children, presence of hydrocephalus is seen only in about 15% of patients. Most of the craniopharyngiomas are ACP, uh, that is adamantinomatous type in children, while they are more commonly papillary in adults. And accordingly, the mutation of beta catenin as well as mutation of BRAF is seen in children and adults respectively. In children, almost 15% patients present with endocrinological deficit, while in adults about 30%. Calcification is seen in more than 80% patients in children, while it is seen in about half the patients in adults. And the greater uh, resection rate has been reported in children, though that is something which we'll be discussing for rest of the uh, lecture. Clinically, the patients present to us either with neuroendocrine disturbances or with neuro-ophthalmological deficits. Sometimes in our part of the world, we still see a lot of patients presenting with raised intracranial pressure, and very, very rarely you will find these patients presenting with motor deficits or psychological symptoms. And patients require, with rapid deterioration of vision or sensorium, of course, require immediate attention. So basically, goals of treatment in all these tumors remain the same. To improve vision is the first priority, of course, and to decrease the raised intracranial pressure. And the third priority, cure from the tumor, comes with a big caveat that you must preserve a good functional status. And these are two similar children. I actually treated this child in 1995, almost 25 years ago. And we have had a radical resection of this tumor by a terional approach, which was commonly done at that time. And this boy actually played football for his school, college, and is working as an executive today. While the other child, we had again a complete excision done here by an interhemispheric approach. And this child had a difficult post-operative period and has developed a you can see premorbid obesity. though he's functionally independent, he's still suffering from a lot of. So you try to do a similar kind of operation in two patients, but you may not get exactly the same result, and there are several factors involved in this. Basically, Cochrane collaboration, when they looked at several systematic reviews, found in craniopharyngiomas that in 44% intervention was likely to be beneficial, 7% intervention was likely to be harmful, 49% evidence was that it did not support either benefit or harm, and 96% recommended further research. So we are in a state of flux. The main areas of controversy remain extent of surgical resection, choice of surgical approach, and use of adjuvant therapy, which one and at what time. And the main reason for all these confusions is probably the adherence and the gliatic plane around craniopharyngioma, which can affect the hypothalamus and the pituitary stalk quite badly. And in fact, the classification which is most commonly used, described by Christian Centros and Puget Stefani from Necker, is of the hypothalamic involvement. And it has clearly shown on the good MRI images that you can assess grade 0, grade 1, and grade 2 involvement. And depending on that, you should probably decide if you are going to resect this completely, and the prognosis depends on this. The only reason I have a little this classification is a little suspect in my eyes is that we use frequently cyst decompression as a procedure, and you find that where you could not see hypothalamus properly or thought in what it was invaded does not seem to be so after doing that when you do a second MRI scan and when we are thinking of a definitive treatment. So these appearances may be to some extent not 100% accurate. There is a classification done by our Korean friend, which largely depend on the fact that where does it originate from. We know that it originates from the Rathke's pouch, and it originates along the pituitary stalk. But many of them originate probably below the dura, and like the pituitary tumors, they take the dura around their dome. So many of them which have regular configuration at the top probably have dome of a dura over them, and the tough tissue can probably allow you hypothalamic separation well, where when the dural dome is completely broken or the tumor has completely grown in the subarachnoid or intraventricular near the very top of the stalk, you may get a completely intraventricular or subarachnoid tumor. There have been several issues taken out by various journals, including our own National Journal on Craniopharyngiomas, which I had the opportunity to edit several years ago. And you can see the number of opinions are as different as the number of surgeons who are treating these patients. So basically what we are talking about is from evidence-based guidelines, when they cannot be established at organizational or institutional levels, we probably go on evidence-based individual decision-making, which is what probably drives craniopharyngioma treatment today. If you look at the 5-year and 10-year survival, the superiority of radical resection is clearly visible. But when you talk about subtotal resection with radiotherapy, the results become more or less similar at 5 years, though at 10 years, a radical resection still seems to be having a better survival rate. However, we are talking of only survival here. If you look at the comparison of the tumor control rates with various treatment strategies, and this is a meta-analysis of 442 patients, one of the initial attempts in 2010, it shows us that the 2-year and 5-year progression-free survival rates for the GTR group as well as the STRA plus a radiotherapy group remain virtually the same, 98 versus 99 and 98 versus 95%. And similar kind of a study done for child nervous system by Nalin Gupta's group in US has also shown that a study of more than 531 patients, 109 studies have actually shown the same thing, progression-free rate of 84% versus 76% and 73% versus 43% for 10 years. So you have almost very similar results. And the best reason, I think, why we have to look at other parameters other than only progression-free survival and overall survival is the limited utility despite accuracy of the SEER database. The SEER database gives you a good idea about the progression-free rate and the overall survival rate, but does not give you the quality of life. And I think that is a major issue when we are talking of a tumor like a craniopharyngioma. So when we are thinking of surgical approach and we think that it makes a difference, currently there is a no consensus regarding the best surgical approach for a large suprasellar craniopharyngioma. The classification given by SAMI for microsurgical approaches is very widely practiced. And I think that really depends on how the tumor is growing. But most of the look at this, that if there is a salar tumor, it is best approached probably through transnasal route, either microscopic or endoscopic. If it is an intraventricular tumor, predominantly, which is rare, about 6% of tumors are intraventricular, you will probably choose a transcranial intraventricular approach, either by microscopic or endoscopic, while the suprasellar tumors require a greater degree of freedom. And one of the deciding factor may be the concept of dural dome, if you can identify, like you try to do on a pituitary tumor as well. So when you look at suprasellar tumors, you have prechiasmal tumors and retrochiasmal tumors. And since the days of Matson, we know that transcranial approaches to prechiasmal tumors have achieved satisfactory excision rate with low morbidity. However, retrochiasmal tumors have a much higher morbidity and mortality. Therefore, for prechiasmal, I think terional, bifrontal, or endonasal, all routes probably would remain the same. But for retrochiasmal, I think probably because of the direction of the tumor growth and the fact that there is a higher morbidity in transcranial surgery for hypothalamic damage, probably today endoscopic endonasal approach may be superior. There is a very nice article which is published 5 years ago on a three-dimensional kind of a topographical model which has been described, and that can give you some idea about the hypothalamic invasion, the involvement of the infundibular area by the, and that can actually give you a better idea as to what will be a good approach. But they have also seen that majority of cases are probably better seen by the endoscopic approach. So I think we will talk about what we do today. We would do a transsphenoidal surgery for a patient where there is tumor is limited mainly to salar or infradiaphragmatic area and is predominantly cystic. And this is one child, 13-year-old girl, who presented with visual problems, and she was found to be mildly hypocortisolism. She was given steroids and she was operated by a transnasal. So those of you who are familiar, you will realize this is a binostril approach and you are already reached the salar floor here. And I'll probably show you another video how you get there. And then you typically make an opening into the salar dura, and you open a little bit of planum sphenoidale here to get to the anterocranial fossa. You have to, of course, ligate the intercavernous sinus. In this case, it has not been so important, and you have a good exposure of the tumor. And once you see that, you start removing the tumor, you remove the calcium, and then you start dissecting the capsule away from rest of the gland, and you can actually find that you will be able to see the gland which is above this lesion stuck to the diaphragm, and you can actually see the small, after making a sharp dissection, you can actually see that the sort of compressed gland is there right on the top, and you can see the depression of the stalk over there. This is a post-operative scan 3 months later, and this is actually a 3-year follow-up. This girl is not on any medication for DI, which she received for first 3 months, and she is on some cortisol and thyroid supplements. That brings us to the suprasellar tumor. So suprasellar tumor, if you really want to do endonasal approach, it has to be, you have to clearly see if it is pre-infundibular, transinfundibular, or post-infundibular. And this is the classification given by Kassam, and you can see that usually clearly. This is a 9-year-old girl who's got, the pituitary is sort of pushed behind. You can see the infundibulum is going like this, and the tumor has come down here and is all in front. And this kind of a tumor is relatively easy to do. You are again making an incision in the cellular dura, and then you are making an incision in the supracellular dura. Then you are ligating the intercavernous sinus, opening that. And once you have opened that, you start seeing the calcium, and you start removing this tumor now, exposing it further. And you have to be prepared for a CSF leak. And most of these children should have a nasoseptal flap to repair their dura, which is now possible. And we have a very good ENT colleague who does that. And that is probably one of the requirements for this kind of surgery. So you can see the normal pituitary gland lying behind and the tumor being removed from in front. And usually you end up into the third ventricle when the tumor is going behind. And you will find that you can see the stalk nicely, and you can see the foramen of Monro nicely. And in the interpedunculaire fossa, you can see the basilar artery nicely. And this is a girl after 3 months with a normal, with the scan without any residual tumor seen, and she's growing up reasonably well. Another child where we have actually a sort of transinfundibular, where you cannot see the stalk very clearly, though the gland seems to be just underneath. The stalks is not so very well seen. And you can see while doing the dissection, I realized that the stalk, the calcium is badly stuck to the stalk. And we were able to remove that tumor, but with great difficulty we were able to, this is the stalk to which the tumor capsule is very badly stuck. So we had to leave a little bit of tumor behind, which is being observed right now. Large tumor where it is there is a retrochiasmal cyst, like in this patient, will have to be removed by drilling the dorsum sellae. So it becomes quite an extensive skull-based procedure, but the tumor can be removed without causing much deficit to the patient. And this lady, now she's a young lady. She was operated when she was 17. She is now with cortisol and thyroid supplements, but is leading otherwise a reasonably good life without any residual tumor 7 years after surgery. Ventriculoscopic surgery for cystic retrochiasmal craniopharyngioma is being described by various groups now. We have a very limited experience. This is one of the patients which I treated with, in fact, the idea that I'll partly remove this tumor, decompress it, and later on maybe I will consider a radical resection. But by removing septa after septa, I managed to get this tumor out completely. And this patient again has remained without any further growth of the tumor for the last 4 years or so. We have also started doing, if the patient comes with raised intracranial pressure, rather than putting a EVD or doing a shunt, what we try to do in a patient like this is first to put a reservoir down the cyst, drain the cyst so that the hydrocephalus is also taken care of, and the cyst is also partially decompressed, which we feel that makes it easier for us to go for a second stage. And then we go second stage after 4 or 5 days by a transnasal transsphenoidal approach. And we find that it makes it much easier to do dissection from the hypothalamus, and we are getting much better resection if we follow this kind of, you can see that the dome of the tumor comes down nicely. This is the catheter which was left behind, which was removed later on. But you can see that virtually the top of the tumor, you do not find much damage to the hypothalamic structure. Again, this boy for the last 3 years has remained tumor free and has not had any radiation. So, recent article on pediatric craniopharyngiomas as a primer to skull-based surgeons usually advises that the general algorithm, you should form your own algorithm for treating an individual patient, looking at the tumor consistency, looking at the extent of the tumor, and looking at the hormonal status of the patient. And they have also found in a study of about, I think, 80 cases or so, that the safe maximal resection with hypothalamus sparing is probably better achieved by endonasal approach. And they make a recommendation that outcomes appear to be optimized by consolidated multidisciplinary care, and you should probably do this surgery only highly experienced centers. There is another meta-analysis of endoscopic surgery for pediatric craniopharyngioma, which again shows you that it's a safe alternative to other surgical procedures, and the rate of excision remains almost the same as the craniotomy. What about the cases where you cannot completely achieve it? This is a difficult patient where we first drained the top of the cyst with a transventricular approach, and then we went endonasal. This is after this is the residual tumor. Sorry, this was after the ventricular catheter insertion, and this is the transnasal surgery. And though we are able to remove, we thought we removed a lot of tumor, we have left some tumor behind. And we actually subjected this patient to proton beam therapy. He had remained reasonably intact, and this is the result of the radiation. 1 year later, this patient has come back to us again on no medication for diabetes insipidus, but he is receiving thyroxine and cortisol, which where in fact even pre-operatively he had low levels. So when do we actually subject a patient to craniotomy? A predominantly paracellular tumor, like what is shown on the picture above, when there is heavy calcification, if there is a vascular encasement, if there is a history of previous injury to the vessels during a previous surgery in a recurrent patient, and if there has been a previous radiation. So this is patient, this is a post-Gado scan. You can see that both paracellular areas are involved in this. This is about an 18-year-old boy, and we did a pterional approach. Again, the best thing that happens is you get good corridor between the lateral to the carotid, between the carotid and the optic nerve, and then between the two optic nerves, and you can remove tumor from these various areas. Usually the tumor is not adherent to the vessel walls, and you will find that gradually you can debulk this tumor, and if you are patient enough, you will be able to remove the tumor. Towards the end, we have used endoscope to make sure that we have removed all components of tumor going into the various spaces and making sure that the whole tumor is out. And that is one advantage. You can use endoscope even in transcranial surgery, and this is a post-operative scan at I think 4 or 5 months, where you can see that there is hardly any residual tumor, and this patient is being observed. This is a 17-year-old girl presented mainly with visual failure, a very, very calcified tumor. I did not dare to do it by a sphenoidal approach. We did it with a transcranial approach and managed to remove this tumor to a large extent, and then subjected this patient to radiotherapy. This is the post-operative scan in that patient. And this is another patient who actually was treated elsewhere. The patient already had a compensated ischemic problem, where you could see that one carotid was already damaged, and we decided not to uh, go for any transnasal surgery. We did a limited decompression in this patient and subjected her for radiation. Other modalities, we have to think about what kind of radiation we are going to use. There are also possibilities of local chemotherapeutic installations, and we will talk about molecular biology. So basically, whenever you do partial decompression, almost 70% of the patient recur within the first 3 years. And therefore, I think there is a more and more tendency that if you know that you have left a tumor behind, upfront radiation is given. If you feel you have removed the tumor completely, you will wait till you see either the residual tumor on post-operative scan, or you would serially follow these patients up and make sure at least for a couple of years that there is no tumor growing before you say that you will not give radiation to this patient. And time of recurrence is usually within the first 3 years, though many tumors can recur even after that. I have a patient who recurred almost after 11 years. And radiation following subtotal resection seems to definitely give a better long-term recurrence-free survival than subtotal resection alone. And I think there are various figures in this. There is a meta-analysis of 32 papers which show that tumor control increases from 40% to almost 100% in a 5-year follow-up. Complications of radiotherapy are of course there, and you have to be very, very careful about the optic neuritis, and therefore SRS has not been very popular with us because very few tumors, residual or recurrent, are away from the optic nerves, though it seems to be a very popular approach in Europe, and it seems to be working at least in some centers quite well. Radiosurgery for craniopharyngioma. So this is actually one of our colleagues who's now working in Pittsburgh, and they have shown 3-year and 5-year progression-free survival rate as good as SRT. And this is a Japanese multi-institutional study which again has shown that if the remaining tumor is less than 3 centimeters and is away from optic nerves, they can achieve a very good control rate. This is the only patient we have treated where there was very little tumor growth seen after about 1 year of surgery, and we have treated this patient with SRS with gamma knife. Proton beam therapy seems to be used increasingly, especially in the United States. And in India, we have recently acquired it, and I showed you one patient where we have been able to achieve. One of the things is that it seems to have almost the similar kind of tumor control rates as photon or the SRT. However, the results are much faster. The tumor reduction is seen in a much faster manner. There is always worry, as the next paper shows, that the complications have not yet been given, but I think people who are treating this for more than 5 years now, we should know their results very soon as to what are the side effects of proton beam therapy. Intracystic therapy is occasionally given to patients where you find radical resection is difficult, the tumor is mainly unicystic, and the child is not still in a position to be given radiation. We initially used bleomycin in 6 patients, and we found that it was difficult to use because leakage of dye was fairly common in the cyst. In the last 7 patients, we have used interferon, and I'll show you one case afterwards, but these are the 2 main drugs which have shown to be quite effective, though long-term results have not shown very promising result. You need to follow this treatment with something else. This is one of our patients where we used bleomycin for about 2 years till the cysts kept on collapsing, but then there was a recurrence again, and we had to eventually go for surgery in this patient. So the Cochrane database review has also not been able to show a clear benefit of bleomycin. Since we started using interferon, this is one patient where we have not had to operate at all. The cyst has virtually completely disappeared, and we could take it out after about 2 years' time. While all other patients have required a follow-up therapy, and it can certainly delay disease progression and probably gives you time to go for a definitive surgery or to go for radiotherapy. And I will end up with this patient. Is a 4.5-year-old girl. Recently, we have treated. She was operated elsewhere, and within 1 year, she has come back with a. This was the first surgery post-op pictures, and within a year, she has come back to us predominantly with the intraventricular cyst. We first thought of going for surgery, but then the child was in a poor state. Hormonal imbalance had made it very difficult for her, but her vision was getting worse, and we decided to put in a reservoir, which we did by a simple endoscopic procedure, made sure that it was not leaking, and then we treated her with uh, uh, intracystic interferon by the Toronto protocol, and the cyst reduced to a very, very large extent. And at this stage, we actually put the question to the child's parents that if they would like to go. By this time, she was becoming 7 years, and would she go for radiotherapy or go for a surgery? And they opted to go for surgery. So through the same track of the reservoir itself, we managed to remove this catheter and dilated the same tract, and we have been able to remove this completely. I won't, and this seems to be the post-operative scan. So she is under observation right now to decide if she would need further radiotherapy. Basically, the major worry now that with improvement in surgery and good perioperative kind of workup with our intensivist, endocrinologists, etc., more and more patients are surviving. What is their endocrinological status? And in Falbush's old paper, it seems that he found that the results were similar of transcranial and transfemoral surgery. but the hormonal replacement therapy was more often required for transfenoidal cases, while a recent paper in 2000, sometime after that, showed that radiotherapy and extent of tumor removal did not have uh, much effect in terms of the hormonal outcome, while the recent paper in 2015 also shows that the which kind of a treatment is offered to the patient probably does not decide. The main thing that decides is if there has been any hypothalamic damage preoperatively or during surgery, which would make a substantial difference. So basically today, I think the standard of treatment is a posterior thalamic sparing surgery, and which route you choose depends on your team's philosophy, expertise, and it is still very likely that you may not achieve more than 50% patients where you will do able to do a GTR. For the other patients, radiotherapy can be used, intracystic therapies can be used as a temporizing measures, but what else after that? And there comes the role of molecular pathology, which has shown that beta-catenin inhibitors might be able to help in adamantinomatous craniopharyngioma, while BRAF mutation agents have already been, I think, beta-catenin have been tried in a couple of patients where results are now available, which have shown dramatic therapeutic responses, and the future will tell us if these are going to solve the problems of craniopharyngioma, which we have still not been able to solve satisfactorily so far. In our experience of 114 cases, 160 procedures, we have done endonasal procedures in 40, and all other procedures have been done at various stages. And the aim has been to preserve endocrinological function in these children. Thank you for a patient listening, and I'm happy to answer any questions.
Thank you, Professor Del Pucciari, for a wonderful presentation. I think you showed nearly all possible methods of treatment of craniopharyngioma. And I see we have 3 questions from the audience. So first question is, Professor, would you recommend radiotherapy even after an apparently gross total resection? I think it's also important to say about timing of radiotherapy. Should it be immediately after surgery or delayed?
So I think the only situation where I would advise upfront radiotherapy is a patient who's more than 7 years old and where I know that I have not been able to achieve a good excision. I think in other patients, if I think I have been able to do a good excision, I have been able to do more or less a complete excision, I would wait till the tumor shows up on follow-up imaging. And in a child below 7 years, I usually like to wait. I may consider another surgery, or I may consider a, time buying treatment like intracystic chemotherapy.
Okay, thank you. And yet my question to this, did you meet patients with secondary malignization, with malignant transformation of craniopharyngioma after radiotherapy? Because we have had one such a patient.
Luckily, not yet. I've not had a patient where the tumor has turned malignant or any other malignancy developed in a craniopharyngioma patient, fortunately.
Okay, thank you. And the next question is from Professor El-Beltaji. How many children and how young did you operate by endoscopic endonasal approach and achieved gross safe total resection?
So we have done about 40 cases. We have, I think 29 of them were children. The youngest child we have operated endonasally is 3 years. We reported this in child's nervous system last year. Our experience of these 30 cases, and it has been possible to do in that particular child, it was possible to remove the tumor completely. I think the age of the child has not been an issue in terms of removing the tumor. It is a problem sometimes for approach, and we have not used it below 3 years. In fact, I have two other children below 3 years whom I have operated transcranially. Uh, so in those 29 patients, I think we have gross total excision in about 17 and subtotal resection in 12 patients.
Okay, thank you. I think it's the answer for the question. And the next question is from Serge Edimba from Zimbabwe. Is chemical meningitis from leakage of cyst content a problem you have encountered in your practice? If yes, how did you deal with that?
Nowadays, we are using alpha interferon as I told you, and fever and headache following injection of the first injection is fairly common. So we first give a test dose, and if the patient has such a thing, we wait for about a week and then we again give a test dose before we can do that. And we have been 7 patients where we intended to treat, we have been able to treat them all. It has not been an issue. In bleomycin, it was a bigger issue. If we saw leakage, we did not actually use it because there is a well-known toxicity even to optic nerves and hypothalamus.
Okay. Naren, can we continue with questions? Do we have time for that?
For the want of time, as Dr. Komar Prasad would say, I think we probably have to go to the talk of Professor Morota. But Professor Dear Pujari, there are lots of questions for you on the chat box.
I will see if I can answer on the chat. And welcome, Nobu.
Okay, so thank you very much, Professor Pujari. And we can go to the next lecture. Pascal, can you continue, please?
Hi, morning. Can you hear me?
Yes, yes, very nice.
Hi, good morning, everyone. So it's a great pleasure to introduce the second speaker, who is Professor Morota. As you all know, Professor Morota is the chief of the Department of Neurosurgery of Tokyo Metropolitan Children's Hospital, and one of the few neurosurgeons able to master both neurosurgery and IOM. There are very few at the moment in the world. He trained also in New York with Professor Epstein and Professor Deletis, and has a great experience in the surgery of pediatric spine dystrophies and IOM. Many of you will be familiar also with this recent classification of spinal lipoma based on the embryology. So please, Professor Morota, we will listen with the great attention at your presentation on IOM for pediatric spinal surgery. Thanks.
Thank you. Good evening. It's night time in Japan, and today I'm going to talk about the interventional physiological monitoring in pediatric spinal surgery. And okay, this is our interpretive setting of the surgery here and the monitoring here. And first, talk about, okay, this is not a spinal case, but sometimes we encounter like this case, a very tough case for pediatric neurosurgeon, and take the tumor out and pre and post-op. And like this case, the interoperative neurophysical monitoring is the indispensable surgical procedure for critical surgeries. And the topics today I'd like to talk to you is what is the interoperative neurophysical monitoring, especially for the pediatric neurosurgery, and interoperative neurophysical monitoring in conjunctive junction surgery and the lump surgery surgery with these issues. So the first of all, what is interoperative neurophysiology? Okay, this is the one is evoked potential monitoring. This is the monitoring the functional integrity of the central nervous system. This is the mapping the central nervous structure. This is a functional localization to aid the surgical procedure. And this comprises the interoperative neurophysiological procedure. The aim of the monitoring is the functional preservation, and the mapping, the localized the functional surgical anatomy. And the appropriate application of the interoperative neurophysiological procedure or combination of these procedures This is critical for tough cases of pediatric neurosurgery. So craniovertebral junction, we have like this case, and thoracic, cervical thoracic. This is a extradural arachnoid cyst. Or in the lumbosacral, we have the sacral cyst, or the like this very complicated terminal cyst being there. And for pediatric spinal regions, pathology of the pediatric spine or spinal region differ based on the location of the region. And craniovertebral junction, the congenital regions associated with bone anomalies are common, and the surgery is often technically demanding. And the lumbosacral region, anomaly relating to the spina bifida is common. The region often extends inside the dura and intermedially. So indication and the role of intraoperative neurophysiological monitoring differ from different regions and the different locations. So like this is the achondroplasia. We concern about the preservation of the motor function and the respiratory function. But if you can preserve motor function, usually respiratory function is okay. So I concentrate on the monitoring for the motor potential, like in this case. This is the case of spinal dipalma, and we concern about urinary preservation of urinary function and leg motor function. But leg nerves, motor root, come to the ventral to the dipalma. So I concentrate more on the preservation of urinary function. The variable cavernosus reflex monitoring is more important. So there are many modality of monitoring. So supertensional, maybe multiple potential, critical mapping. For the first, including brainstem, we can monitor critical tract multiple potential or brainstem mapping. And craniovertebral junction, multiple potential, cervical thoracic region, multiple potential, and lumbosacral region. So these variable cavernosus reflex monitoring and dental mapping and nerve root stimulation for motor. So, and I talk about this region today. Okay. So this is the background of my experience of craniovertebral junction surgery. More than the carry one and the achondroplasia consists of more than half of my experience. Sometimes we encounter like this very complex congenital anomaly, a bone anomaly of the cervical craniovertebral junction. And this is post-op, the post-op fixation, and we do this kind of surgery. So we concerned about intraoperative neurophysical monitoring. It starts even before surgery. What it means, the confirmation of the spinal cord compression at craniovertebral junction at the time of head fixation. So positioning is very important for like this complicated cases. And you can make it safe if you use intraoperative neurophysiological monitoring. Okay, this is the case of achondroplasia, and monitors record the body potential before positioning. And after positioning, again, record the multiple potential and confirm it's safe, the position is okay. In this case, the position is a little bit neutral to the extended a little bit. This is before positioning. Left side, right side. This is after positioning. Sorry. This is after positioning. The response is there, and you can feel it's safe. This is the end of surgery. The multiple potential present, and suppose the surgery is okay. And actually, in this case, what happened? This is my early series in my experience of the achondroplasia. The compress is completely decompressed. But what happened during surgery is that at this point, the the multiple potential aggravated suddenly and then lost completely and gradually recovered. And by estimation, what happened at this point is, okay, at foramen magnum, craniovertebral junction, the spinal cord is compressed by the narrowing, and I drill from the dorsal like this. And when you drill like this, the dura expand after decompression and comes like this. And at this age, something happened for the neural damage. So after this experience, I changed my procedure. I shaped the bone as thin as possible, and then within a minute or so, I decompress completely. So the nerve tissue expand evenly, and nothing happens for the monitoring. So this is only one case in my experience for this kind of deterioration of the motor potential during the decompression by quadriplegia. Okay, this is a change of the positioning. This is a Qadri one. This is a neutral position, but you see this here is a basilar impregnation in this case. And what happened while I was washing my hand, monitoring technician ran up to me and said, MVP has gone. So I returned to the OR and changed the head position more extended position. And immediately after the positioning of the neck, MVP returned. So it is so critical, if you know what you are doing and how much of the flexion you can be allowed, it's very important for safe surgery and to make the surgery easier. So it's like this, if you have the Zyl, you have a rope, if something happens, you can limit the damage as small as possible. You may fall or the avalanche starts from your foot. But if you have the rope, you can feel safe. It's the same for surgery. If you have monitoring, you know what happened and you can limit the damage as small as possible. So the interpreted neurosurgical monitoring consists of evoked potential monitoring, function preservation, and the mapping, functional localization of the surgical anatomy. And combination of both monitoring and mapping is crucial for comprehensive preservation of the central nervous system. And for surgery of the cranial junction, the MVP has the primary role of interpreted neurophysiological monitoring. The MVP monitoring is important at the time of visioning, and spinal cord compression by overexpression could be avoided. And furthermore, appropriate cervical flexion enables to perform a safe and smooth surgery. And now I move on to the lump sacral region. Okay, these are the issues I'm going to talk about: the bulb cavernous reflex monitoring and the parental mapping and the combination of both procedures. And this is the background of my surgery for occult spinal bifida. And for monitoring, I use the bulb cavernous reflex monitoring and the mapping, parental mapping, and the nerve root stimulation. This is for motor stimulation. And this is a schema of the interpretive neurophysiological monitoring for lump sacral regions. This is the bulb cavernous reflex. This enables the monitoring the whole reflex circuit of the unity function. And for afferent pathway, we use parental mapping, and afferent pathway, motor pathway, and direct nerve root stimulation. And now the first I talk about the bulb cavernous reflex. This is easily enabled to monitor whole reflex circuit. This disadvantage of the bulb cavernous reflex is easily influenced by anesthetic regimen, difficult to monitor when neurologic bladder pressure exists before surgery. And usually BCR consists of two components, R1 and R2. R1 is the oligosynaptic reflex and more reliable than R2. So we usually monitor R1. This is a simulation parameters for simulation and recording. This BCR monitoring was first introduced in 1997 by Dr. Pedro Deltes, my mentor in neurophysiological monitoring. And at this time, there was no criteria for interpretive alert. What is a warning sign? And I talk about it later. So this is the position of the electrode. For simulation for genitals, you put the electrode on the genitals, and the recording for the anal, use a needle electrode to the perianal muscles. This is a visceral response. So if you use a terrain, increase the number of terrain, you have more robust response. And I usually use a terrain of 5. Some recommend to use a terrain of 7 or 8, but I usually use a terrain of 5, and only use when I lost the response, I use a terrain of 7 or 5. And simulation intensity, if you increase the intensity, you have the robust response. But for safety point, the maximum simulation intensity is 40 milliampere. This is my rule. Okay, this is a BCR during surgery of lipomyelin meaning cell like this. And from bottom to up, the time cyst. And the response is stable. The patient had no neurological deficit after surgery. Okay, sometimes this is what I call the type 1 spinal lipoma for 3 months old. And this is after dural exposure and cut the connection to the subcutaneous tissue, lipoma. After untethering and the removal of the spinal lipoma. This is before, and this is the end of lipoma resection. And what happened during surgery, you see at this moment, there was deterioration of the BCR, and later on it recovered, and the patient had no worsening of the urination at the end after surgery. This is a very unusual case. This is a huge spinal lipoma. And if you look at here, this is the subarachnoid space, and this is what I call the type 1 spinal lipoma. And before removal, and this is after untethering and the removal of the spinal lipoma. And in this case, this is post-op MRI. At the beginning, there is no response from the right side. The left side, there is some R1 response here. On the way, there is some response, delayed response appeared. And at the end, this very disorganized but very strong response appeared in this case. This is very unusual. Usually, what happens during surgery is loss or deterioration of BCR. So now I move on to the warning criteria. So if you are doing surgery, you need the warning criteria. What happened, what is danger, or what is the risk? So this is a paper I published last year about what is the warning criteria for the bulbocavernosus reflex monitoring. So this is a case, type 1 spinal lipoma, and during surgery, BCR suddenly lost, and later slowly recovered, and then aggravated, and then lost, and then recovered again. So this is a baseline BCR. Left side, there is no response from the beginning. Left side, you could record BCR. And at the closing, if you increase the intensity, you can get the response. So what will happen? What happened in this baby? This is the question. So in my paper, I made the 3 groups. Group 1 is cut off at 50%. So the 50% of the amplitude remained. And group 2 is the cutoff is 25%. So the 25% of the amplitude remained, 75% reduction. And group 3 is present or loss, above 0 or 0. The cutoff is 0. And if you look at the urinary function, in this zone, one cutoff 50%. Okay, the positive predictive value is only 25.8%. Negative predictive value is 100%. In zone 2, cutoff 25%. The positive predictive value is only 53%. And if you do 0% or loss, the positive predictive value is 100%. So my conclusion is that for functional prediction, present any remnants of the BCR or no, 0. This is you can predict the functional outcome. But for clinical warning, clinical use, practical use, the 25% would be safer. So reduction of 75% would be allowed. So in this case, the baby had no worsening of the urinary function after surgery. However, in this case, this is type 3 spinal lipoma. The mind is a stable BCO, but suddenly lost. And there is no BCR appeared at the closing. And the patient discharged with a clean intermittent catheterization. No function recovered. Now, I'll show you some videos. This is a type 3 spinal lipoma. And this is the pre-op BCR, very stable, beautiful recording. This is post-op MRI. This is post-op BCR. Some reduction and increase of the threshold, but the BCR remained. And urinary function was fine. But what happened, okay, this interpretive photograph, this is type 3 spinal lipoma. There is no dural deficit. And it's after opening the dural. And separate the cauda equina from the spinal lipoma, and untethered, and reduce the spinal lipoma. And I encountered this kind of neural tissue, the terminal cyst or something. This after the myeloplasty before dural crossing. Okay, this is a BCR. BCR is stable at this point. And I keep cutting the small remnant of the lipoma. And here comes the neural tissue. And there, the reduction of the BCR recorded, but still I'm working. And at this point, the monitoring doctor alarmed me. So I stopped. I stopped the procedure and worked. And then slowly it recovered. So I resumed the procedure, and like this, it returned. This is another case. This is type 1 spinal lipoma. This looks like a lipomyelomanic, but the conus is preserved. So I assigned this as type 1 spinal lipoma. And this is a pre-op resection BCR, a very stable, beautiful response. And this is a response at the dural closure. So some reduction, but still the response was preserved. So this is interpretive photos. And during the cutting, I again opened the cystic component here. Like this is neural tissue. And this is a myeloplasty before the dural closure. And in this case, here the BCR is stable. I cut the remnant of the lipoma, and here I open the terminal. But the BCR remains stable, so I continue the procedure. It is stable. The neural tissue is exposed, but it's okay. So I continue procedure. The BCR remains stable, so I can go on, and yeah. I remove the remnant of the spinal lipoma. So now I move on to the pudendal mapping, and this is a mapping of the afferent pathway of the pudendal nerve. This is initially invented for the use of rhizotomy. And this is a parameter. This is a response. And in this case, the left S2 and right S2 has the highest amplitude of the action potential of the pudendal afferent. And interesting, this is first introduced also by Bedram. And this is, in his data, the S3 has the highest amplitude usually have the highest amplitude of the placental afferent. And Dr. Ogiwara, he was my colleague when I was working at the National Center. And we checked the Japanese data. And in Japanese, the placental afferent often have the highest peak at S2. So what it means for mainly Japanese, the Asian data and mainly Caucasian data has the S3, Japanese Asian data has the S2. There may be some ethnic background difference for the distribution of the placental dorsal action potential. And so we combine these procedures together during the surgery. Like this is a 9-year-old girl with the spinal Dipalma type 3. And this is put up. And during surgery, after removal with the spinal Dipalma, I found the two fibrous tissue. And I'm not sure if this is functioning or this is just a skull of the tissue. So I made a placental mapping and that simulation and confirming there's no response, then I cut them. So this is the placental mapping, no response, and that mapping, no response, and the simulation also shows no response. And cut it, and the BCL, there's some fluctuation, but remained. So this is put up, and this is the baseline BCL. This is the post-op. And yeah, the threshold increased, but the response remained. And the patient stayed the same condition as at discharge. So this is the last case I can present today. This is a 28-year-old female with the anterior huge sacrum meningocele. And there's some fibrous tissue coming inside, and the spinal cord is completely tethered. During surgery, this is a left S2, and the placental mapping showed the highest amplitude dorsal action potential here. So this should be preserved. And this is a left aberrant root. There is no response, no function coming in. Also, the direct circulation showed no motor response. And this is right S2, also shows the placental action potential here. So this should be preserved. And this is a thickened filum terminale, and there's no response. And the direct stimulation also showed no response. So I cut this filum terminale, this aberrant nerve root, and then close the orifice of the anterior meningocele. And the patient was happy with the resolution of the symptom with no deficit. So the BCR monitoring plays a critical role to preserve urogenerative function during surgery for lump sacral region, especially for spinal Dipalma. And the combination of intraoperative neurophysiological monitoring and mapping enables to preserve and prevent damage to the urogenerative function during surgery for lump sacral anomalies. Direct explanation and mapping the spinal cord together with the BCR monitoring are indispensable for functional preservation during surgery for lump sacral region. And this is a recommended book recently published from academic press. And also, these are the papers. I recommend you to, if you have a chance, please take a look at these papers. So this is the end of my presentation. Thank you very much for your attention.
Thank you very much, Professor Morota. Beautiful presentation. There will be dozens of questions, but we have not much time. I'm sure for the young residents, it will be good to know about the Morota classification. So I just put the reference here on the chat so you can understand when Professor Morota was speaking about type 1, type 2, type 3, what does mean. We have time for one brief question, which I have seen here from Mohammed Sumon Rana to Professor Morota. Cord lipoma, total removal is always not possible. True? Well, I think we can, yeah. I leave you the answer, which is very complex, but
Okay, how much you exercise the lipoma is not the main issue of my presentation, but in my classification, type 1 spinal lipoma, you can try to remove a total excision, but usually I do the subtotal excision. This is safer. And usually, if the lipoma is large, the site of the lipoma almost always includes the nerve root. So the subtotal excision is safe. And if you come close to the spinal cord, you can directly smell through the lipoma. Okay, my experience is if you use a 0.6 milliampere simulation, and you can get the response, you are very close to the nerve root with 2 or 3 millimeters. This is my suggestion.
Thanks. Yes. To summarize for the young trainees, yes, it's possible, obviously, to resect in some cases completely the lipoma, according to the classification of Professor Morota, particularly the type 1, where you can find what Pang defines as a white plane that Sandeep was speaking about this morning. In type 2, it's much more difficult to achieve a complete resection because I mean, you have elements, neural elements mixed with the fat, so it will be very difficult to achieve and is not recommended. Type 3, you can, it's when the posterior elements are completely intact, so but this connection is enough in that case. And the type 4 is a simple fatty phylum lipoma, so obviously you can achieve it. So, but you can read the paper and go ahead and go and find all this. I think we can, thanks Professor Morota again. We can probably move to our next speaker if Marek is there. Marek?
Aaron?
Yeah.
Okay. Now I'm all right. So we can go to the next presentation. Who is the presenter is Dr. Anna Matteo. She is from Italy, from the Department of Critical Care in University of Messina. And as I noticed, she is author of several significant papers on the topic of critical care, also with neurosurgical problems. So, Professor Matteo, could you start with your presentation on the diagnosing of brain death, please?
Yes, thank you. Can you see my screen?
Yes.
Yeah, we see everything.
Yes,
is okay.
perfect. And so thank you very much to everybody, and thank you very much to Narendra for this very kind invitation. And it's indeed really a privilege for me being today here. I am an anesthesiologist and intensivist, so it's an honor for me to be part of your Neurosurgical International meeting. And I am extremely grateful to Narendra because he accepted to reserve a space for this topic, which I believe is a very important one and should be part of the medical university curriculum everywhere in the world. And so let's start with some numbers. And here is a very large epidemiological investigation in 145 pediatric intensive care units in the States. And it was observed that almost 20% of the death declared during this 5-year period were declared according to neurological criteria, that is brain death. And the causes of brain death was mainly related to hypoxic and ischemic acute injury owing mainly to cardiac arrest, and 20% of brain death were declared after a traumatic brain injury. Less frequent frequently in the child population the other causes. The median length of stay for these patients is 2.5 days. And interestingly, if you look at these graphs, you can see that the number, there is a linear correlation, association between the picosides and the number of brain death declared over the years. The best way, it goes further, blocked. So, sorry, the best way that we can start talking about this topic is to understand the pathophysiological mechanism that is behind the brain death. Irrespective of the cause, that could be hypoxia, ischemia, or trauma, or hemorrhage, when we have a catastrophic brain injury, we have a massive edema. And this will be responsible for an increased intracranial pressure that will spread all over the brain, and this will determine also compression of vessels, and at the very end this process will be spread all over the brain, usually from rostral to a caudal direction. And when the intracranial pressure will overcome the systolic arterial pressure, then the cerebral circulatory arrest will occur and brain death will occur. And for younger people that are listening today, I would really ask, when you deal with this topic, we should all be using a very clear language. So after catastrophic brain injury, if we talk of a coma, we are still talking of a patient who is alive. But when we talk about brain death, we talk about death. And so what is that? Several definitions have been used in the scientific literature. And just to be very pragmatic, we can say very firmly that the person is dead when his or her brain is dead. And brain death is defined as the irreversible loss of all the function of the brain, including the brainstem. And of course, we need medical standards for determination of brain death. And this has been published not only for adults, but also in infants. Actually, the criteria for determination of death by neurological criteria are consistent all over ages, with few peculiarities for children. And when we talk about diagnosis of brain death, we talk of a clinical diagnosis. And the three main components of this diagnosis are lack of consciousness and responsiveness in a comatose patient, absence of brainstem reflexes, and apnea. And before starting the diagnosis, never forget to check for essential prerequisites that are the certainty of etiology. You have to be sure what was the cause of the catastrophic brain injury. And neuroimaging that you have been doing to treat this patient need to be consistent with the catastrophe that is going on in the brain. And because it is a clinical diagnosis, no confounders should be present. And so you have to exclude this before starting with the diagnosis. So no hypotension, no hypothermia, no metabolic alterations that could confound the clinical diagnosis. And of course, no sedative and analgesic. And in the case in which cardiopulmonary resuscitation has been done in the patient, you should delay the examination for at least 24 hours. And most importantly, each single step of your diagnosis needs to be documented. And this is extremely important. And the literature shows that sometimes documentation is not complete. The neurological examination should be systematic, rigorous, complete, and as we said, no motor response or eye-opening response to painful stimulation. We have to document the loss of all brainstem reflexes, and here you can see the list that we have to elicit in the patient, and they have all to be absent bilaterally. And apnea test, that is, we should demonstrate that there is no respiratory trigger in a drive in the patient when we reach a high level of CO2, that is over 60 millimeter of mercury, which is recognized to be adequate stimulation for the respiratory centers if they are alive. And how to perform the apnea test? Continuous monitoring is imperative. You have to start when the patient is normotensive, normothermic, euvolemic, eucapnic, and no hypoxia. You should pre-oxygenate the patient for 5 to 10 minutes, and then you should start from a normal level of CO2. And you then disconnect the patient from the ventilator. And during the time that the patient will be disconnected from ventilation, you of course have to preserve oxygenation, either attaching the patient to a TPs, either leaving the CPAP to avoid the recruitment. And during this period that could last some minutes, 5 to 8 minutes, because CO2 will rise 4 to 5 millimeters per minute when the patient is not ventilated, you have to observe closely the patient for any respiratory movement. And then you have to document with a printed arterial blood gas analysis that you have reached at least 60 millimeters of mercury. Of course, sometimes, but it's not so frequent, you can interrupt the test if the patient becomes very hypotensive or there is a severe desaturation. In these cases, you have, as you do not have a complete clinical examination, you should ask for ancillary study to be performed. And sometimes during the apnea test, but also during the clinical examination, you can see spinal cord reflexes. These are compatible with brain death and are essentially due to a spinal cord which is deprived of superior control. Some age-related consideration. There are two examinations to be done, separated by an observation period. Observation period may vary according to the age of the children, and it's 24 hours for neonates, 12 for infants and children. The diagnosis cannot be done in preterm infants of less than 37 weeks of gestation age, and for children less than 1 year, the use of ancillary neuroimaging diagnostic tests are suggested together with the clinical diagnosis. And these tests, so when should we order a confirmatory ancillary test? We should order these tests together with the clinical diagnosis only when the clinical neurological examination could not be complete for any reason. For example, you have a severe maxillofacial trauma that impede the execution of some reflexes, or in the case you cannot exclude any other confounder, or in the case you have to interrupt the apnea test, or in the case your children is less than 1 year. And essentially the ancillary tests are done to demonstrate the absence of cerebral blood flow And we have different tests that are available in different hospitals. You can use either cerebral angiography, and you have to document the absence of both anterior and posterior circulation, while external carotid circulation remain patent. And you can use medical nuclear medicine, demonstrating that there is no uptake in the brain of this lipophilic agent that is usually administered and uptaken from brain when it is perfused and viable. So this is what you will see in brain death. And you can use transcranial Doppler. You need, in this case, to have an expert operator, and you have to perform at least 2 exams at an interval of 30 minutes. And these are the typical patterns of brain death. Or you can use computer tomography angiography, and you will have to demonstrate the absence of filling of intracranial arteries, while external carotid arteries should be normally visualized, because this will confirm that you do not have any hemodynamic compromise. And of course, you can also use as ancillary tests also neurophysiological tests. EEG is one of the most used all around the world, and still, for example, in Italy, it's mandatory. In this case, when you use EEG, you have to remember that EEG may be affected by some confounders. So you cannot use EEG to confirm, for example, if there is hypothermia or hypotension, or if there is any residual drug. You need to demonstrate absent cerebral blood flow. And when you are dealing with little children and you are performing a cerebral blood flow study, because it's required by the clinical situation, sometimes it may happen that you have a residual persistence of cerebral blood flow in the case of non-fused suture, or if there has been a decompressive craniectomy, or if there are ventricular shunts. In these cases, you will have to postpone again after hours the test. And if there is something that if any of you could ask, is there anything that at the bedside can suggest the clinician that the patient is going towards brain death? I would say yes. If you say at the bedside, there are some neurological part of the examination that will orient you that something is changing in the brain. But there are also some very frequent signs that are polyuria due to diabetes insipidus and hypothermia. These are really very frequent at the moment of the transition. And from an hemodynamic point of view, hypertension and bradycardia, followed then by refractory hypotension, is also very typical. And at this moment, the goal of the clinician at the bedside has to change from neuroprotection, because that patient is dying, and you have to document that he has died. In this moment, you can offer to this patient the opportunity to be organ donor. And so when you diagnose his brain death, you never should forget that you have to maintain adequate circulation and oxygen delivery to maximize the number of quality of transplantable organs if the patient will donate. Some specific challenges we should never forget in pediatric population that are appropriate support of family. Communication skills are very important, and because of course these are rare events, the importance of simulation and training. And just to conclude, brain death determination, like any other medical procedure, require training and practice, we should be expert in this when we perform this diagnosis. The importance of documentation, the importance of family support, and then never forget that transplantation depends on organ donation, and brain death patients are patients that can be organ donor. Thank you very much for your invitation. And I can listen and answer to your questions if there are any.
Thank you, Dr. Matea. You presented us very precisely the criteria of brain death in children. I think it may be very difficult for us. I think we always need anesthesiologists to help us to interpret them and to use them. And I found till now one question in the chat. And the question is I think, more or less obvious. Is this evaluation same in adult or different? I think it's of course, it's different.
Is the evaluation? Sorry.
Is the evaluation of the criteria the same in adults and in children?
Yeah, so they are consistent all over the ages, and with few peculiarities, as I shown, but the medical standards of loss of consciousness, of responsiveness, apnea test, and no brainstem reflexes are the same in children and in adults.
I think the protocols are different depending on the country, yeah? Because,
yeah, this is another important
in Poland,
this is
we have to make instrumental studies for children that are not necessary in adults.
Yeah, so the worldwide, there are a lot of difference also in national laws, actually. And
right.
So there is actually, during these recent years, there has been an attempt from all the societies to try to make this not the criteria, because the criteria, the medical criteria are the same, but what can be different is the duration of the observation period, the number of doctors that are involved in the diagnosis, the specialty that are the specialization of the doctors that can do this diagnosis. So there is an attempt for a better uniformity all over the world, and this is really very important to be performed.
Thank you very much, Dr. Matea. I think we have no time for more questions. However, could we ask you to have a look in the chat and answer some more questions which appeared just in the moment in the chat.
Thank you very much.
Thank you very much. And Gallo, could you?
Thank you. Thanks, Marek. Thanks, Professor Matea, for this beautiful lecture, which touched the ethics and the law of all European and worldwide countries. But we move to the next one, to Professor Elias Rizk. Dr. Rizk is Associate Professor at Penn State University and a consultant neurosurgeon at the Penn State Hershey Medical Center. He obtained his medical degree from the American University in Beirut, Lebanon, and did this residency at the Penn State University with a subsequent fellowship at the Children's Hospital, Alabama. So please, Dr. Rizk, to you the burden and the honor of presenting this challenging and controversial topic of management of arachnoidal cysts. Thanks.
Just a second, sorry. Elias, do you want to unmute your microphone, please?
Are you able to hear me?
Yes, yes.
Okay. Thank you so much for inviting me and allowing me to be part of this wonderful community and wonderful opportunity to present on a topic that's near and dear to everybody's heart in pediatric neurosurgery. But sometimes this is a difficult situation to be in as a pediatric neurosurgeon, and it's not going to be only one or two cases that you're going to see on your career, and you'll see here the statistics as we go about talking about this disease condition. Arachnoid cysts are a really complex condition that we manage on a day-to-day basis in neurosurgery and has several plethora of findings that we need to go about. And I'm sorry if it's going to be going into the details, and hopefully with some coffee, everybody's going to be up and running with this topic to be able to understand the nooks and crannies of this condition. We have come a long way since the Papyrus Edwin Smith medical information from 2500 BC until now, and it took us about 4,000 years until Dr. Bright from the UK, who was actually a nephrologist, who did a very nice case illustration textbook and described the first arachnoid cyst in the medical literature. That was about the 1830s. So for a disease condition that's so prevalent, it took us about 4,000 years to be able to describe it in a gross anatomical specimen. We don't really know exactly how arachnoid cysts develop, but the idea is at the roof of the rhombic roof, the primitive meninges separate into the superficial and the deep arachnoid pia. And I put this from Dr. Pang's wonderful illustration textbook. The idea is at the primitive meningeal syrinx tissues, the CSF starts to be produced and separates this layer into two separate layers in the human development. It is made of arachnoid membranes and lamellar collagen bundles, and the membrane can contain veins, focal capillaries, ependyma, or cuboidal epithelium. Sometimes you can see choroid plexus, and this is more common in the supracellular and the prepontine cysts. The histological imaging, you will see lamellar collagen fibers, cuboidal epithelium, and sometimes you can see some vessels in the structure or membrane itself. There is absence of inflammatory cells unless there is a previous history of treatment or infection. Sometimes you can see some hemosiderin around, especially with traumatic subarachnoid cases or arachnoid cyst cases where patients present with hemorrhages following trauma or independent of trauma. And the brain is usually normal and adjacent to it, and sometimes you can see some evidence of gliosis. There are several theories to explain why the expansion occurs, but none of it can be proven, and you cannot really experiment on this topic to prove a certain hypothesis. Sometimes people discuss that there is a higher protein content acting as an osmotic gradient. Certain thoughts think that the choroid plexus actually produces the fluid and causes the enlargement of the cyst, but sometimes you see an arrested growth of the cyst, so I'm not sure that this fully explains that. And you can also see some cine MRI or contrast studies that show a communication or a partial communication or a ball valve effect causing spinal fluid to be trapped into that cyst. The adjacent cortical hypoplasia with the cyst expansion also could be an explanation of the continued growth of the cyst. Those cysts can be present anywhere in the brain, but predominantly they will be in the supratentorial, sylvian fissure, and in the infratentorial and cerebral pontine cistern. You will have them spread out throughout the whole brain or even intraventricular sometimes and could be missed easily on CAT scans. This is a sylvian fissure arachnoid cyst. This is a hemispheric cerebellar arachnoid cyst. This is a supracellular arachnoid cyst with obstructive hydrocephalus. This is an interhemispheric arachnoid cyst. This is a quadrigeminal supracellular cyst, or even a posterior fossa arachnoid cyst elevating the torcular hierophilus in this individual. You can see how they look like intraoperatively, and I'll show some images and videos on how to treat that and medically manage those. Some patients present with scoliosis or even intraspinal arachnoid cysts. One of the things that we need to not miss out, they don't only exist in the brain or central nervous system, but also in the spinal cord, and can be a cause of management failures or complications when inappropriately treated. Everybody should be well versed with the Galatic Classifications, the type 1, type 2, and type 3. And really the differentiating factor is the size of the arachnoid cyst. So it's in type 1, it's a biconvex subarachnoid cyst that's at the edge of the sphenoid wing. Type 2 is when the whole insular compartment is exposed and slightly more enlarged, and there's a partial communication with the subarachnoid space when you do CT cisternograms. And the type 3 is more enlarged than the sylvian fissure itself. There's bony expansion and bony changes on the CAT scan, and there is minimal communication into the subarachnoid space. It's a prevalent disease. So before the prevalence of CT scan and MRIs, we did not know how often you'll see those arachnoid cysts, but in 1.1 to 0.7 of autopsy cases, you will see arachnoid cysts, and it's more prevalent in intracranial mass lesions and MRIs when they are obtained, because there is usually a reason for further investigation, images, or certain conditions that may or might not be related to arachnoid cysts. Many cysts are incidental findings, and they are usually recognized within the first 2 decades of life. Males have more predominance, but also they can be multiple or bilateral arachnoid cysts. It can be a familiar occurrence, but these are usually rare. The natural history is not well understood, and the majority remain dormant and static. Few cysts progressively enlarge with mass effect, and rarely a cyst involutes and disappears over time. Some can rupture, causing subdural or epidural hemorrhages, or even raise intracranial pressures. You will see lots of case reports. This is a nice summary of spontaneous subdural hematomas or epidural hematomas in the literature so far studied, but you can see, it's not 1% of the population that you will see exposed to this condition, and the discussion of potential correlation to traumatic brain injury will be covered at the end of this talk. Again, management is controversial. Conservative management with serial imaging is very appropriate and indicated. It is usually recommended for patients who have neurological signs or symptoms, elevated intracranial pressure, increased head circumference, head enlargement, patients who are regressing or have an unknown explanation of worsening neurological condition. Additional soft reasons for intervention could be that the cyst can cause brain dysfunction or changes in cerebral perfusion. Both the Volder and Rader showed that there's potential changes in neuropsychological testing before and after treatment, and blood flow has changes along the site that is compressed in that location. Again, this is what you can easily miss sometimes on CT scans with intraventricular cysts, so really watching and carefully studying images and taking a couple of minutes just to review the whole scan and not focus on the initial pathology to cover everything that's inside the patient's imaging. The goal of the treatment is obviously to reduce the pressure, and there are several techniques in the neurosurgeon's armamentarium. Cyst wall excision and fenestration into the subarachnoid space is typically the teaching point here. You can do it either through a craniotomy or endoscopy. You can also do it in a stereotactic cyst aspiration fashion, especially in the interventricular portion. Shunting of the cyst fluid to the peritoneal cavity is also one of the mainstay treatments that a lot of neurosurgeons rely on. The advantages of the cystoperitoneal shunt is usually what advertised is simplicity and low morbidity, but this could be a nightmare when it doesn't go well and CSF starts to leak from one compartment to another or through the skin. So be careful and watch out for these cases. These are not simple and not easy to manage sometimes. You can have shunt infection and end up with loculated hydrocephalus or even much more resistant infection with nitises that are present in different locations that antibiotics may or may not reach. You can have overdrainage symptoms or even hindbrain herniation in patients with posterior fossa arachnoid cysts. A lot of patients complain of low pressure headaches, so they come in with enlarging arachnoid cyst, and you turn their one presenting symptoms of high pressure hydrocephalus into low pressure headaches, and becomes a reason to investigate and treat further and change locations of catheter distally or change with anti-siphon mechanisms. So they're not easy and simple, and it's not something to take lightly before you decide on a surgical intervention. I summarized some of the literature here as far as shunt complications. So you'll have shunt complications in up to half and sometimes, or even infections in about 5 to 10% of the cases. And you can even have neurological damages with just shunt implementations. Craniotomies also can be more radical procedures, and the idea is to disentangle the adherence of the arachnoid cyst from the adjacent structures and create a pathway into the subarachnoid compartment. And up to a quarter of these patients, the cyst can reaccumulate, so don't pat your back really quickly and say that you fixed the issue, so they need to be observed and followed up closely. And a lot of times, even after the treatment, the patient fails and they continue to leak CSF, and you end up needing to put a shunt in up to 30 and sometimes 100% of the cases or case series that I've looked at. The European cooperative study of craniotomy showed treatment of arachnoid cysts has shown that the failure of endoscopy can be in up to a third of the cases. I'm not really sure if this is only because you did a marsupialization or bilateral fenestration into the arachnoid compartment and made sure that there is adequate flow there. 30% ended up with shunted hydrocephalus, and 19% had failure of their craniotomy surgery. Endoscopy is a nice technique to have, and its initial use was in the 1980s, and we migrated some of the urology scopes initially to use it in intraventricular procedures. Powers was the first one to describe interventricular cyst management using the endoscope, and Auer described the first case of Sylvian Fisher endoscopic fenestration of an arachnoid cyst into the subarachnoid compartment. Endoscopes, as everybody knows, could be rigid or even flexible scopes. They're only steerable at the end, and then there's several iterations that you can use. Endoscopes usually have a plan to open normal to abnormal, or abnormal to normal, whichever way you deem safe and have a better access to. The wall of the cyst is thicker near the ventricle, so you need to be careful and know adjacent vascular anatomy, including vessels or veins. I've seen cases of patients ending up with major strokes due to either venous or arterial infarcts. They're more challenging than what you see on imaging, and they really need to be done in a very thoughtful manner and not take any chances while doing the procedure. Always try to fenestrate the cyst wall with a blunt probe. Don't use cautery, especially on the medial portion next to the delicate vascular structures. You can attain hemostasis with bipolar electrocautery, or even just irrigation sometimes can stop small microvessel bleeders. Fenestration, once you get in, you need to make a wide fenestration into the subarachnoid space so you don't end up with a slit valve or a ball valve mechanism. So dilating with a balloon catheter is helpful. And you can use alternatives as fiber optic lasers to maybe coagulate the easier portion of the arachnoid cyst on the cranial portion of the cyst. Again, multiple windows decrease the incidence of recurrence. That's the teaching. I don't have specific data to confirm this except for the suprasellar arachnoid cysts who have shown that the recurrence rates is immediately improved just by creating a pathway into the subarachnoid space. And again, the diameter of the fenestration should be at least a centimeter when you're doing a fenestration. Complications could be disastrous. Sometimes you can damage eloquent cortex and you can really injure major structures, and the carotid artery has been reported to be injured during these procedures. And I talked about my review of my own cases. Minimally invasive does not mean it's minimal risk. It's just, a smaller incision does not mean there's a higher odds or higher risks of causing a disaster in a patient. Treatment by location, supracellular arachnoid cyst, make sure that there is a communication into the subarachnoid cyst, not just marsupialize the cyst. On imaging, you'll see a Mickey Mouse pattern, as I've shown in one of the pictures before with the dilated lateral ventricles on the coronal pictures. And the first treatment has been described in the 1990s with the endoscopic management of the supracellular arachnoid cyst. Now it's the mainstay of treatment, especially after Children's Hospital Boston, Dr. Gubnerova reviewed the data on this and showed that fenestration into the subarachnoid space is higher likelihood to treat those cases. Middle fossa arachnoid cyst, again, plan your trajectory appropriately and make sure you fenestrate in the basal cisterns. There's a higher risk of hemorrhage or injury or strokes with these endoscopically treated. And the idea is to lessen the detachment of the dura and flow into the basal cisterns. Arachnoid cysts in the posterior fossa can also be treated with either fenestrations, craniotomies, or even shunts. But be careful on what you use or treat, because if you overdrain that site, you can cause cerebellar sag and end up with cerebellar hemosiderosis and even complications from an unwanted CSF leak from the posterior fossa, which is really hard to treat. This is a video of endoscopic management of Sylvian Fisher arachnoid cyst. So you can see the size of the incision first and opening of the dural compartment. Make sure you don't widen that window so much so you can actually close the dura at the end after creating your fenestration, so you're able to have a somewhat of a dural tight closure. Here you can see the endoscope going into the cyst itself and trying to get into the basal cisterns along the carotid artery and the optic nerve. So spend some time, study the pictures. T2 KISS sequences or high resolution T2 also allows you to look at the vascular anatomy and the subarachnoid compartments. Here you see the blunt instrument trying to pull out the arachnoid and thicker tissue on the medial portion of the arachnoid cyst. You create your window. It's still not adequate and enough to get into that compartment. Make sure it's nice and wide so this doesn't recur and you cause a ball valve effect. You can see now the spinal fluid or CSF is clearly going through that hole with some form of wave motion of the edges. And you can see the other side still has some layering of the arachnoid membrane. So you continue with your slow dissection and widening into that site. Supremacy of one treatment option over another is not available in the evidence. Do whatever you've been taught by your mentors and do what is safe to the patient and what you seem or deem is appropriate in your own hands. So I cannot tell you to do a craniotomy versus shunt versus endoscopic procedure. Do what you're comfortable with and you know that you're not going to harm the patient. We need a nationwide prospective database to follow this as an outcome and what patients are treated, what size needs to be treated, what location needs to be treated. We need detailed neuropsychological testings on those patients or even more advanced MRI techniques to help delineate this pathology because it's not a unique condition. I placed two cases here from our own experience as far as how to deal and manage with these cases, because you're going to see them in the clinic, in the office. One is a 20-year-old rugby player. Yes, we do play rugby here. Received a blow to the head, and he was found down after 1 minute loss of consciousness, and witnessed an early seizure by his colleagues and the trainer at the field. Due to all this, he obtained a brain CT, then a follow-up MRI, and ended up in the emergency department to be evaluated. So you can see there's a fairly large extraaxial arachnoid cyst causing a midline brain deformity, so it's not an incidental finding. So in this case, you have to ask yourself, what is the data and what you need to recommend to this patient? Do you operate on this? Do you tell the person never to play rugby again or do any contact sports? And we are starting to have more and more information on this topic. Cormac Marr from University of Michigan has really done a nice job talking about arachnoid cysts and the natural history of arachnoid cysts. And in his series, he studied about 185 patients with 46 months follow-up of arachnoid cysts. In this population, about 112 participated in sports. So the cumulative follow-up of monthly numbers of play is about 44,000 months. Of those, more than two-thirds were involved in contact sports. So a cumulative about 3,000 months of total periods of observation in patients who are previously diagnosed with arachnoid cysts and currently playing with contact sports. And from all this, you see that there is no catastrophic neurological injuries associated with the patients who are previously diagnosed. So you can't tell 1% of the population never to play sports and stay on the couch. So it's a public health risk to recommend sedentary lifestyle and not do anything. So really need to think about every recommendations we offer to our patients. So in this case, after he recovers from his concussion, I have no actual medical data to tell him never to play contact sports. And on the other hand, I have very good data showing that at least in the short term, 3 years out, that there is no risk of a catastrophic neurological injury. Not that subdural or epidural hemorrhages cannot happen with arachnoid cysts, but these are rare cases and should be put in context of the size of the cyst and the trauma or non-trauma or history associated with it. The other case that you're going to see in your office is infants or babies who come in with arachnoid cysts. So this one is a 6-month-old baby boy who had febrile seizures, and because of the complex nature of the seizure and the repeated nature, he had a CT scan, and he was found to have a type 2 Galassi arachnoid cyst. His head circumference was at the 58th percentile, and his exam was neurological stable. So in this population, you want to know, is it appropriate or adequate to discharge the patient? Do you, that's the MRI here. Do you have to do anything for the treatment? Does this febrile seizure explain the seizure, or is it the arachnoid cyst that's causing this? Do you continue follow-up for how long? And what do you tell the parents as far as the odds of increasing in size? And again, Cormac Marr has really done a nice job with his colleagues at the University of Michigan. And, you know, the treatment is only indicated if there's concerns for elevated intracranial pressure, bulging fontanelle, raised intracranial pressure, papilledema, or changes in the patient's developmental behavior or regression in their feeding or alertness. As far as follow-up, for how long, in the case series that they worked on, the size of the cyst can grow up to age of 4 years, and they did not see any growth in size beyond 4 years or even in the adult subsequent papers that they published. And the odds of increasing is 11 out of 111 cases or patients that they reviewed, and it's about 10%, and in about 13% the size decreased and the rest stayed stable. So you have about 10% chance of increasing or decreasing in size, and the younger infants or babies that they saw showed an increased size or likelihood of increasing in size. And you can see just in 6 months in follow-up, the size of the cyst enlarged even further and required surgical intervention. That's my summary of arachnoid cysts. I hope I helped as much as possible clarify this topic, and I'm happy to answer any questions.
Thank you. Thank you very much, Dr. It's a beautiful presentation. And as expected, there are many, many questions. I think I will ask you probably to answer them on the chat if you can.
Yeah.
Because we are, unfortunately, we're a bit late. We're running a bit late. You answered few of the questions already with the two beautiful cases that you showed at the end, but there are some other questions you can help answering on the chat. Thanks.
Thank you.
So, thanks to you. Marek, should we move to the last speaker?
Yeah, okay. So we are going to the next speaker, who is Jonathan Roth. Jonathan Roth is a professor of neurosurgery, specialized in pediatric neurosurgery and working in division of pediatric neurosurgery in Tel Aviv in Israel. So his first lecture will be on the topic of cranioplasty. Jonathan, could you start?
Yes, thank you, Marek. Hello, everyone. Can you see my screen right now?
Yeah, everything. Our screen, not yet.
Okay.
We can see you, not your PowerPoint yet. So.
Can you see
now?
it now?
It's okay.
Yeah, we can see now. Yeah.
Okay, good. So I have two talks. The first one is on cranioplasty in children. And I must say, for this talk, I've revised a lot of the literature, and I was very disappointed to find out that there's much more unknown than actually known in this area. So just to remind ourselves, indication of a craniectomy are mostly related to trauma. I'm talking now about children. But obviously, strokes are in children too, and other more rare indications, as you see here. All kinds of craniectomy sizes and extensions. Some are hemicraniectomy, some are bilateral. You can see here some examples. I'm sure every one of you has seen and done these things. And when we talk about the cranioplasty, we need to remember that the indication for cranioplasty is not only a cosmetic, it's also cosmetic. First of all, it's functional. We're talking about the syndrome of the trephined, patients developing sometimes these are focal signs, sometimes these are ill-defined general neurological declines. Restoration of CSF dynamics, this has been dealt quite largely, especially in the adult literature. Physical protection, especially in children, and of course also cosmetics and all their psychological impacts. So the literature about cranioplasty in children is very limited. Most of the literature in children is mixed with adult series. We need to remember that the hardware technology, all the custom-made flaps are running, every day there's a new company with a new chemical texture promising that their flap is the best for whatever indication. And obviously the literature is lacking behind with proving all these technologies. And sometimes the usage of a certain substrate is actually extrapolates from other usages. Sometimes people have been using it for small, let's say, transnasal closures like the Metpor, then it's been extrapolated to the big cranioplasties, etc. So the literature here is very problematic. But there are some things that we can say, and I think most people will agree about. And here I'm going to talk about the technical nuances. Just if I can ask people who should not be if anyone can mute, because I can hear a lot of noise in the background. Whoever is not, okay. So the technical nuances, first of all, is to try and preserve the soft tissues as much as possible and to cover, to make a very good onlay of the cranioplasty, whatever it's made of, it doesn't matter, at the end of surgery. And this means that when you do the craniectomy, try and do the incision, not exactly where you're going to do the bony cuts, but do them more away, do them 2-3 centimeters beyond where you're actually going to do the craniectomy incision. Then regarding the temporal muscle, there have been all different descriptions of how to preserve or not to preserve them. Personally, and obviously there's no proof of it, what I've been doing when I put the bone back, once again, it doesn't matter what it's made of, I cut the lower part of the bone, so I have this defect to preserve the muscle, because if you don't preserve it and you try and detach it, you actually, I think, you're going to be injuring the blood supply to the muscle and it's going to be atrophied. So if we're talking about cosmetics, it's also going to be hampering the cosmetic outcome. Debride the surrounding bone edges from scar tissue. Now, this will always cause bleeding, so this needs to be in a practical, effective way. You don't have to debride every small scar tissue, but this also means try not to use too much of bone wax, which will hamper the what we call osseointegration, meaning that the bone will cripple into the bone flap. Try to reduce the space between the flap and the periphery. Not always this is feasible in all the periphery, so try and have the longest possible adherence between the bone flap and the surrounding. Fixation needs to be rigid. Sutures are good, especially in very young children, but the older the child is, if the bone will not sit in a very fixed manner to the periphery, it will probably lead to a suboptimal position and a final position, and potentially cause a higher rate of resorption. Once again, you need a well vascularized soft tissue coverage we talked about, and this is a thing that is not well acknowledged, but has been described. Never put vacuum drains when you put cranioplasties, even if there's no dura inside, if you don't see the dura. There have been significant morbidities and also mortalities described after use of subgaleal vacuum drains. With all different theories, it's not always clear if it actually causes intracranial hypotension or not, how it causes it, but there are a couple of discussions about this, and this is important. So what are the complications of cranioplasty? The major two complications discussed are aseptic bone resorption. Obviously, this is related to what we call the auto flaps, and infections. There are many other complications, and they need to be acknowledged. Seizures, for instance, have been described in about 10% of cases. Epidural hematomas, they can be avoided by using meticulous hemostatic technique and putting tack-up sutures in the middle of the flap, in big flaps. As I talked about intracranial hypotension, this is a preventable complication. And all different rare things like hyperperfusion during the first few days because of restoration of cerebral blood flow, causing intracranial hemorrhages, implant breakage, especially in brittle materials and in children, displacements and expulsions, especially in titanium mesh cranioplasties. So what do we want from the cranioplasty? We want it to be biocompatible as possible, inexpensive, to be strong, to have the ability to undergo osseointegration, and to have a low infectious rate. So the most common used bone flap is the autologous bone flap, which has an ideal shape, which is good for infants, and especially when it's a big surface, a round, a curved surface. They're cheap, they're available, they're obviously biocompatible. But the other autogenous materials, such as split cranial bone, which is more effective in younger children when there's a ease to differentiate between the two cortical layers. But this usually entails to make a larger incision, and sometimes it means even a separate incision, so there are double surgical sites. People have been using ribs and the iliac crest, but these things are good for smaller defects. Foreign materials, what people call alloplasts, are good, but here there's a plethora of companies and materials. You see here a short list, but it's an endless list. And while we talk, the other companies were inventing it, and it seems to be an endless spit. But you need to remember in children that alloplasts, these artificial flaps, do not grow over time, as opposed to the original bone that once it integrates, it just grows with the child. Here you have an overview table showing you the various materials and the various parameters that they are tested for. So it's the integration, the durability, how much they're strong, growth potential, etc. So there's no ideal material, and I'll talk about it in a minute. Over the recent few years, more and more people have been using the custom-made 3D implants, which can be personalized. There's no need for intra-op sculpturing. You can maximum do some adaptations if needed. They're good, especially for large surfaces and for curved surfaces. There are endless materials being manufactured this way. And if needed, you can always do intraoperative adaptation, but generally saying they come ready to be placed. The problem with these systems seem to be their cost. So this is a case of about a 2-year-old who had a significant midline injury from a heavy glass, whatever that fell from height and tore the sinus and had a significant rupture of the sagittal sinus in the middle third with brain injury next to it. We did a big craniectomy, we ligated the sinus, there was no way to preserve it. And over time, the child did a reasonable well recovery, and we did the custom-made flap. You see here, this is an example of one company, and this is intra-op images. We fixated it with some screws, and this is a child from yesterday. You cannot see it because of his hair, but he has a very nice curvature of the head. So the major problem with autologous bones are what we call the bone resorption, meaning that over time, the bone slowly becomes absorbed. Obviously, this will affect the cosmetics, decrease the strength of the flap, and need for additional surgery in some of the cases. The rate of this bone resorption has been described between 3 to about 90% of cases, and this is obviously very much depends on what you actually relate to. Is it something on the CT, let's say thinning of the bone? Is it a significant resorption that necessitates additional surgery? So the numbers are very wide. There are endless studies trying to find out what are the risk factors for these bone resorption. So generally, people agree that the more bone fragments there are, instead of one big fragment, if there are few fragments, it increases the rate of resorption. Size does matter. Big flaps, the number that has been described is about 75, 80 square centimeters. So flaps that are bigger have a higher rate of resorption compared to smaller ones. Etiology of the craniectomy, if it was a stroke, if it was trauma, etc., does not seem to be associated with the rate of resorption. Now, there are a lot of conflicting studies regarding other parameters. For instance, age. Some series say that the younger the patient is, the higher the rates are. Some say the opposite, but there is a tendency towards saying that younger age increases the rate of resorption. Gender, once again, it's inconsistent. Possibly in females it's higher, I do not know why. The time from the craniectomy, for every paper stating that the shorter time is beneficial, there's a paper saying that the longer time is beneficial. So once again, I do not know the answer. And once again, a lot of the literature comes from mixed series. Presence of shunt, if it was before surgery, put concurrently or put in the future, once again, conflicting evidence. But you can generally say that in infants, there's a higher rate of bone resorption. There's a higher rate of need for recranioplasty. And that if there's a subdural collection adjacent to the bone, for some reason, it decreases the rate of the absorption. So here you see, once again, a summary of many series talking about the rate of absorption. You see numbers going from smaller numbers to higher numbers. I will not go into details. The summary is as I said. Another factor in children is remembering that they have this ability for spontaneous bone formation. The best example is a craniectomy for craniosynostosis. You see there, sometimes in babies, you have after a few months, you have a reclosure of huge defects. So this ability, which is obviously much more pronounced in infants, still exists in elder children. I had a child of 7-year-old who had a significant, not total, but significant reduction in the size of the defect over time. You need to be aware of growing skull fractures in the remaining defect. So this case of a 1-year-old had a significant head injury, had a bilateral craniectomy, and after about a few months, I wanted to put the bones back, and one side reossified spontaneously, the other one had a cranioplasty. She's obviously devastated neurologically, and you see the curvature is very similar, and actually over time, I cannot tell what side I operated and what side closed spontaneously. Time to cranioplasty. Well, generally, it's not associated with peri-op complication, risk of infection, surgical site infection, etc. We do know that the closer you do the cranioplasty, there are studies showing that it gives a better neurological outcome, especially if you do it below 3 months, and people talk about 6 to 7 weeks to be also an important number. Two series that looked at ultra early, within about 1 month, cranioplasty showed a non-increased risk of infection and also an easier ability to perform the dissection of the soft tissue. One paper talked about low rate of seizure, and there was no change in the risk of hydrocephalus. A paper published a few months ago summarizing the pediatric data shows that if you compare the banked bones, meaning the autografts, the autologous grafts, compared to the alloplast, the rate of infection, this is the rate of infection, was much higher in the banked bone compared to, for instance, titanium and fresh bone, but obviously fresh bone is not a factor, so titanium. And you see that the rates of infection of other materials was relatively high. But when you looked at what they called surgical site occurrences, that these include also bone resorption, also seromas, also other problems, then the rate was much higher in the banked bone compared to the artificial bones. Bone flap preservation is another issue people have been talking about. Well, how do you preserve the bone? Do you do cryopreservation? And here some series have been talking between 8 degrees Celsius to -80. Most series are around the -80. Or subcutaneous pockets, such in the abdomen or thigh, which are sometimes less relevant in a child, but still some centers do this. So a series that looked at the literature up to about 2015 summarizes cryopreservation compared to abdominal preservation, looking at the rate of infection and the rate of resorption, and the rates were generally similar with no significant change between both preservations. So either way seems to be good. Another study looking at the cost of cranioplasty techniques, comparing the computer-generated implants, the 3D implants, to autologous bone, generally stated that there's no significant increase in the overall treatment cost. I think this is a bit hard to extrapolate, and every center and every country has their own calculations here, but generally speaking, at least in that country, I think it was in the USA, there was no difference. So what are my take-home messages? The time to perform the cranioplasty, it's debatable. However, seems to be an added time, an added value doing it at an earlier time, probably below 3 months, and if possible, even lower. Obviously, this depends how's the skin, how's the child, etc. But the earlier, the better. There's no consensus on materials. Probably doing it at an earlier stage with a well-preserved single flap. You can put the original flap. However, if it's let's say if the bone flap is not a single one but has several parts, if it's a longer time since surgery, then probably it's better off putting a custom made. This is a good review about pediatric considerations in cranioplasty. So for whoever wants, I think you can enjoy additional small details. Thank you.
Thank you very much.
Okay. Thank you, Jonathan, for a very complete lecture. I think it's very important from practical point of view lecture. I think we have really no time for questions. Maybe one question from the chat about the age border for artificial materials like titanium used for cranioplasty. Could you very shortly answer this?
Once again, what is the question?
The youngest age that allows for using artificial materials like titanium for cranioplasty.
Well, I don't know this answer, and actually, I used the Listserv platform a few months ago for the case that I just showed you. That I did a custom made for a more or less 2-year-old, and I asked people's advice, and there were no clear answers. And also in the literature, I did not find any clear answers. I just put what I put. It's MetPor, 3D custom made, etc. So in the meantime, it's doing its job. I don't have a good answer.
But do you think is it possible in infants?
Well, I'll tell you, if he's a real small infant, probably he will reossify spontaneously quite a lot of the defect. Now, if he's a bigger child, then, you know, let's say if he's 1.5, 2 years old, I would just do what we did and just put him some kind of either an alloplast, or, you know, if it's someone that you can do autografting from a different region in the skull, or split bone, then use that. I know that in New York, where I did my training, they used to do split bone for these cases. So these are the options.
Well, it's difficult in infants to split the bone too.
Yeah, but
okay.
take ribs. I mean, the alternatives.
Could you also answer in chat some questions more? And Pascal, could you continue, please?
Yes.
Yeah, I'll do so later.
You're right.
Okay, we'll go on to the next talk.
Yes, we go. Thank you very much. We go to the next talk on
Good.
Ilia. Please.
So the next talk is about pediatric syrinx, and I must say this is a very, very wide and controversial topic, because it takes you to discussion about how to treat Chiari, and I think how to treat Chiari, you need a full day, not 15 minutes, and even then, whatever you're going to say, you're going to be in trouble. So, but I'll show you what I have. Anyway, etiology of syrinx: 90% of pediatric syrinxes are associated with Chiari, but you remember that there is a DD, such as intramedullary tumors, tethered cord, they will usually cause a terminal syrinx, MMC, trauma infection, and others. So we're going to focus on the Chiari, but just to tell you that if it's an incidental syrinx without a Chiari, I would just do a proper full CNS MRI with contrast to rule out other reasons.
Jonathan, Dr. Roth, we can't see your PowerPoint presentation.
Okay. Can you see it now?
Yes.
Okay,
Right.
so this is the first slide actually showing something. So this is a case report we had from a few years, just showing you that you need to be open-minded, because this was a case that presented with a posterior fossa arachnoid cyst behaving like a Chiari with a membrane between the posterior fossa cyst and the spinal subarachnoid. So actually, this membrane was acting like a lower tonsil, like a herniated tonsil. So this child, we just opened up the posterior fossa cyst, and the syrinx went away. So what can we say about the Chiari malformation and syrinx? About 30 to 70% of Chiari-1 are associated with syrinx. Usually it's a cervical, but can be also thoracic. There are all different theories how this syrinx occurs. I will not go into it. They're all debatable. There's a plethora of literature discussing what supports and what doesn't support. Generally, beyond the water hammer, I think what's interesting is this, the last one, talking about the fact that the syrinx may be related to a reduced pressure in the spinal subarachnoid region and not an increased pressure. But anyway, I'm going to be more practical. This is an ultrasound. I'm going to tell you what you're going to see, and then I'm going to run it. That shows you an intra-op finding. This is the tonsil. The patient is prone. This is cephalad. This is caudal. This is the cervical spine, and this will be the brainstem and cerebellum. Cerebellum here and tonsil here. You see here the upper part of a syrinx. And what we did during surgery, we used electrophysiology, and they did MEP testing. And we're going to see when they do the testing, look at the distortion around this region, just to show you the impact of this Chiari. So I don't know how much you saw, but there's a significant distortion. We don't really evaluate this thing from a single, from a stills MRI. So this is something that intraoperatively is shown very nicely. Symptoms of syrinx, obviously there can be the symptoms of the Chiari, which I will not go into, but there can be scoliosis in quite a few of them. Sensory, and here you need to remember the sensory dissociation, because usually the superficial and deep sensation will not be affected, as opposed to the pain and temperature, because of their path in the center of the cord, while they go from the certain level to the posterior columns, to the spinothalamic tract. Then varus muscles and muscle weakness and spasticity, loss of bowel and bladder control, this is very rare. Chronic back pain, this is quite often. And or cranial nerves, which may be involved. Here it's a bit hard to differentiate. Are they involved because of the Chiari itself or possibly syringobulbia? But at least the rest are quite common, especially the scoliosis. What are the indications to treat the syrinx? So first of all, the symptoms of Chiari itself. Second, in holocord, large syrinxes, you need to treat them even if you think that the person is asymptomatic, because the functional reserve of the cord is limited. And if you wait till the patient will have symptoms, usually at this point, they will be irreversible. And obviously, clearly symptomatic syrinxes, even if they're smaller. This is a survey that Paul Steinbock and his group published in 2017. This is a redo of a previous survey from, I think, 2013. And what they looked as, what do people recommend? They saw that in incidental Chiari without syrinx, most surgeons, 94, will not operate. If there's a small syrinx, once again, same patient, 70 would not operate. And if there's a significant syrinx, then most would operate. But if it's a symptomatic Chiari, the threshold to operate with a syrinx, even a small syrinx, was much, much lower. So this is a 6-year-old kid with Chiari that presented as a baby with swallowing problems and underwent an FMD at the age of 6 months. Everything was good, had a good recovery. And then 6 years later comes in with some new pain in the lower extremities, has an MRI showing this, what seems to be a holocord syrinx. You can see it going down also to the thoracic region. So what should we do at this point? So I'm going to leave this question and talk about a more general question. What are the treatment options in failed FMD? So there is limited literature about this question. Most literature discusses how to treat Chiari with a syrinx. It does not talk about what to do in a failed Chiari syrinx. So treatment options vary. They can be redo FMD, a syringopleural or syringosubarachnoid shunt, and I cannot talk about anything about Chiari without talking about the Atul Goel's conception, which I must say, we cannot ignore this. I know it's very much not popular to talk about it, but the world cannot ignore this option. I went to Atul Goel about 1.5 years ago, and I must tell you, until you see these patients, it's all mumbo jumbo. When you see how much these patients improve under your eyes, it's amazing. So coming back to the question, treatment about failure of Chiari with the syrinx, we looked at 48 patients who had an FMD and also had a syrinx before surgery to look what happened to them. So 50%, 25% of the total had a progression of the syrinx, but we had another, about the same number, who had persistence. So it makes up about 50% who did not reduce their syrinx. And the symptoms were seem to be quite often either staying as they were or progressing. And only a small percentage of patients had no symptoms over about 3-4 years of follow-up. We did see that in extradural FMD, there was less of a failure of the Chiari syrinx condition to an FMD. So we built some kind of an algorithm. Dr. Judah Solomon published this, and what Judah showed is that eventually, if you exclude hydrocephalic CSF issues, which obviously need to be treated as for their problem, and if the FMD was done properly and sufficiently wide, then you should offer them, or you can offer these patients the option of a syringo subarachnoid shunt. And I'm going to talk about this shunt. Syringo subarachnoid shunt, this is another paper by Jehuda, is basically opening the cord in the midline, usually in the midline. There are conditions where we'll go through the DRES, usually in the midline, and connecting between the internal cyst and the subarachnoid region. I'll show you a film in a moment. We've shown the importance to use electrophysiology during syrinx surgery because, first of all, while you do the myelotomy, you have to make sure that you're in the midline. Not always the anatomy is clear enough to identify the midline, and sometimes you can stimulate and check the SCP and verify that where you get a right-sided response or a left-sided response. Another indication to use IOM and MEP is when you place the catheter, it will tell you if it's pressing on any motor region. We had 2 cases where it warned us and we repositioned the catheter. Was it a must or not? Obviously, it's hard to say, but it does seem to be some value. So this is the film I told you, just to show you how a syringo subarachnoid shunt looks. So this is, it's a 2-level laminectomy, opening the dura, finding the midline, which I think is a crucial thing. Usually you can identify it anatomically, either by the arteries, you see the direction of the arteries from both sides that going through the middle, or you see the 2 DRESs on both sides and you see the midline in between. And like I showed you now, the stimulation, you buzz the PI, you open with an arachnoid knife along, in parallel to the fibers, and with a plated bayonet, you open the cord and you put a catheter which is connected in the other side to the subarachnoid space. I did not focus on it at the beginning, but we dissected the subarachnoid space to have an opening for this catheter. So 21 patients in our series that underwent an SSS, and the outcomes were good, both in imaging and in neurological conditions. So to finalize, in children, the first line is treatment for Chiari-related syrinx is more and more extradural FMD. I think most people have, or many series, have described the added value with less complications of the extradural compared to the intradural. But once again, this is a very debatable topic. FMD for Chiari and syrinx that have failed, it can happen even years after surgery, so these patients need to have long-term follow-up. And what you can offer these patients is either a syringo subarachnoid shunt or redo FMD, and obviously to rule out other causes such as hydrocephalus. So this 6-year-old boy I showed you, we did a syringo subarachnoid shunt. The child recovered. This is his follow-up MRI, and he's fine. Thank you.
Thank you very much for this beautiful presentation, Dr. Roth. I will ask you to answer the question on the chat if you can, because we run out of time, and I think we need a bit of break before the next epilepsy session.
Sure. Thank you very much.
Thank you, Jonathan. I think that's a fantastic lecture. We have after the break, we have a fantastic session on epilepsy surgery with Mr. Walsh, the most senior neurosurgeon in UK, with Professor Radka, who everyone knows, and also from Carlo FCO, who's from Vatican and Rome with a huge epilepsy program, and Dr. Sulma with her laser ablation. That is something new that will be of interest. But I just wanted to thank every speaker for this fantastic session and masterful moderation and chairmanship by Prof. Mandera and Mr. Gallo. All the lectures from the morning session are on the listserv YouTube channel, so you can go through it and study it again and again. Thank you very much again. Have some stretch your legs. We have got 30 minutes before a really master class in epilepsy surgery. Thank you. See you soon.
Thank you.
Thanks a lot.
Thank you, everybody.
Thanks. That's good.